Hello and welcome to another episode of the TheSynapse eLearning sessions. With us today we have Prof. Michael Borg, who is chair of the National Antibiotic Committee, and will be speaking about antibiotic stewardship in the local community practice. Thank you, Prof. Borg, for being with us here today.
Thank you for the invite, as always.
Thank you. On to our first question. What can you tell us about the local antibiotic susceptibility patterns and how this data is able to be accessed by physicians in the community and in clinical practice?
Okay, so antibiotic susceptibility information is very useful in order to guide policies in terms of antibiotic stewardship. And when we're talking about antibiotic stewardship, we're meaning proper antibiotic use. So you always need to prescribe according to your local patterns. Now, this is something that GPs often raise, and it is a valid point, and it is something that the National Antibiotic Committee is working on. One of our biggest drawbacks is, in fact, that our sources of data are not as good as we would like them, because at the moment our data is based primarily on a restricted number of isolates, which very often are sent after treatment failures. And that is something that we would like to work on. We would like to work on a sentinel system in order to have the data coming really from patients with a first-time infection. Because if you just take the data for patients who've suffered treatment failure, then that can be slightly biased. Having said that, the data that we have is the data that we can use at the moment. And on the whole, as Rochelle mentioned, our resistance in the community is thankfully not as yet that severe. So on the whole, our resistance is relatively acceptable, with a few important exceptions which we will talk about today.
And in fact, if I may ask you about specific pathogens of note, for example, Streptococcus pneumoniae as an important pathogen in the etiology of bacterial respiratory tract infections, what is the local data showing with regards to penicillin resistance?
Now, in terms of Streptococcus pneumoniae, as you said, at this time of the year, this is a very important organism. It is the most important organism when we are talking about lower respiratory tract infections, especially pneumonia. So this is an organism where you primarily aim to cover when you are treating severe pneumonia or serious cases of lower respiratory tract infections. But thankfully, although when you look at the literature, you see a lot about penicillin-resistant strep pneumonia, thankfully our local strains are as yet relatively sensitive. In fact, as we can see from the graph, the resistance to Streptococcus pneumonia to the beta-lactams is very low. Our sensitivity rates are almost 100%, and they are also sensitive to the respiratory quinolones. But we all know that the beta-lactams are the first-line antibiotic for lower respiratory tract infections, and in fact, amoxicillin is still a very effective agent for lower respiratory tract infections such as pneumonia, including in the elderly.
And what can you comment about the incidence and prevalence of MRSA in the community? What does the local statistics show?
MRSA is something a bit different. So MRSA, here we are talking about Staphylococcus aureus, and therefore we are concerned about any infection that Staphylococcus aureus causes. And now Staph aureus is probably one of the most versatile organisms, as I'm sure the audience, doctors in the audience will remember from their basic microbiology. And it causes a wide variety of infections. But in the community, of course, the key infections for Staphylococcus aureus are those of skin and soft tissue. So infections of the skin, especially diabetic ulcers, very important organism there. Infections of post-operative wounds. So post-operative wound infections, of course, Staph aureus has to be your first organism. And just to do some summary or some recollection, Staph aureus is very often present on the skin. About a third of us, if not more, are commensals for Staphylococcus aureus, and that is where the infection starts in the beginning. So it starts as a commensal, which then develops into a pathogenic infecting organism. So, in terms of resistance to Staph aureus in the community. Now, when we look at our data, we find that, in fact, now I have a different scenario. We said for Streptococcus pneumoniae that sensitivity is very good, it's very high. With Staphylococcus aureus and its susceptibility to oxacillin or else flucloxacillin, sensitivity is not as good as we would like it to be. Historically, we have always said that we know that we have an issue locally with quite a high prevalence of carriage of MRSA even in relatively healthy individuals. So that is an issue of concern. Having said that, when we look at the data for Staph aureus, we find a number of patterns. So first of all, most resistant Staph aureus, in other words, most patients with MRSA, if you actually talk to them and take a good history, you will identify that they would have had exposure to a healthcare facility. In other words, they were very often hospitalized or else needed some form of hospital management. And that is clear. Secondly, the other major risk factor for MRSA is previous antibiotic use. Okay, so again, if you look at patients and you look at the literature related to community MRSA, previous antibiotic use is particularly relevant. Okay, so if you have patients who have been in hospital, who have had one or maybe even more courses of antibiotics, then those patients are at risk of MRSA. The other thing that we are seeing is that up to maybe 2014, about 40% of isolates of Staph aureus from patients who had gone to health centers, which are mainly our primary source of community isolates in terms of surveillance and in terms of epidemiology. So about 40% of these isolates from swabs of patients or pus or urine which yielded Staph aureus were resistant to oxacillin. So up till 2014, about 40% of all Staph aureus isolates from community samples were MRSA. Over the past 3 years, we are seeing this number reduced. So now we are in the region of around 70% that is sensitive. The latest figures. And this is because of the screening that we are doing at Mater Dei and the decolonization. So patients are leaving the hospital at a lower risk of being colonized by MRSA. So where does this sort of bring the picture to the average general practitioner? I think on the whole, unless you have a patient who is either has a known past history of MRSA. So as I said, every patient coming into hospital to medical, surgical, orthopedic wards nowadays is screened. So in the discharge letter, if that patient is positive, you will have that information there. So if you have a past patient who has a history of MRSA, then of course if that patient develops a skin or soft tissue infection, you have to be very aware that it could very well be MRSA. The second thing is the patient who has had recurrent antibiotic treatment in the past, and we know that cephalosporins and quinolones are important drivers for MRSA. But other than that, if you have a patient who has had no antibiotics, no previous exposure, then it is really acceptable and I would say safe to start with flucloxacillin, because flucloxacillin, although from the tables and from the graphs we see that there is a level of resistance, but as I said, very often this is pretty focused on specific patients. Now, if the patient does not improve, then there are other alternative oral options. As we can see from the chart, doxycycline and especially cotrimoxazole are still two very effective antibiotics for Staph aureus, even for MRSA. So these two antibiotics are especially useful for skin soft tissue infections. I would just point out that although it does cover Staph aureus, one should be very careful about using quinolones, because quinolones, as I said, ciprofloxacin, levofloxacin, whilst they can be effective, number one, our MRSAs are primarily resistant to it, so our local strain shows very high resistance to quinolones, and secondly, quinolones themselves are a driver for MRSA. So flucloxacillin is a first line with doxycycline or cotrimoxazole. If you're suspecting MRSA, is probably the treatment of choice locally for Staph aureus.
Profs, with regards to local antibiotic resistance, are there any major issues which you wish to comment even more about?
Yes, definitely. So we've mentioned Streptococcus pneumonia, we have mentioned Staphylococcus aureus, but we haven't mentioned the other one of the big three, and that is E. coli. Okay? E. coli is a key organism in the community. It is the number one cause of urinary tract infections in particular, and it can also cause other infections. And this is where the concern for antibiotic resistance in the community locally is. Okay, so in terms of resistance, if there is one area where I would really be very careful and very apprehensive, it is E. coli and its resistance. And what we're seeing in E. coli are two phenomena. First of all, the first phenomenon is extended spectrum beta-lactamase producing enzymes. So these enzymes basically, as their name suggests, break down the beta-lactam ring. The beta-lactam ring is the centerpiece, it is the internal backbone of every penicillin group, a group of antibiotics. So what we see is that these enzymes actually break down the beta-lactam ring and render the antibiotic ineffective. Now, the extended spectrum beta-lactamase are the most potent of these enzymes because they can break down practically all the beta-lactams. So all the penicillins, all the cephalosporins, first, second, third generation, all of these would be rendered ineffective by ESBL. Now, our ESBLs at the moment seem to be relatively stable, but the level is not astronomically high. But nevertheless, it is still a worry, because very often what happens is that these patients end up needing hospital treatment, and when they get into hospital, if they are ESBL positive, you have very, very few treatment choices that you can make. So what drives ESBL? Well, again, it's always the same story. It's the antibiotics, and in the case of ESBL, it is particularly quinolones, and it is particularly cephalosporins. So second generation cephalosporins, all of them, third generation cephalosporins are even more potent drivers for ESBL. So again, this is an issue. But the other big issue, and it's something which I think very few GPs are actually aware of, is the level of resistance in E. coli for fluoroquinolones. At the moment, about 40% of community strains of E. coli tested at Mater Dei show resistance to ciprofloxacin. And if they're resistant to ciprofloxacin, they will be resistant to all the quinolones. They will also be resistant to levofloxacin, enofloxacin, you name them, they will be resistant. And as a guidance, we always say that if resistance in a bug, in a microbe, exceeds 20-25%, then that antibiotic should be used with extreme caution for empiric treatment. Okay, so what we're saying is basically, if we have 40% of quinolone resistance in E. coli in the community, one should be extremely careful, cautious, apprehensive of using ciprofloxacin for urinary tract infections in the community. Okay, and that is a key concern. Okay, that is something that we really need to hammer home.
That is quite interesting, the 40% rate. Why do you believe that such a rate has been obtained here in the community?
Well, once again, I think the main issue is use. Okay, so in fact, if you look at this graph about antibiotic resistance and consumption within the EU, and this is produced by the European Centre for Disease Control following pan-EU surveillance, you will see that the same countries that have high levels of quinolone resistance also invariably have high levels of quinolone use. Now, it is rather nonsensical to say that these countries use quinolones because they have resistance. So the arrow is in the opposite direction. Okay, the resistance always follows the pattern of consumption. So our consumption of antibiotics of the quinolone group in Malta is relatively high compared to other countries.
We're speaking about antibiotic stewardship, so obviously it makes sense for us to speak about the prescription practices of physicians in the community and even in hospital with regards to local antibiotic use. Is there any data?
Oh yes, there's a lot of data that we have. First of all, we know from European studies, because we're part of a very extensive and very active European network, that there are a number of facts that we know about. First of all, Malta seems to have one of the highest level of antibiotic prescribing in Europe. So I think we've said this already in the past, about 50% of Maltese will tell you that they have been prescribed at least one antibiotic over 12 months. Okay, in about 20% or 30%, they are prescribed 2, 3, and sometimes even more antibiotics during a year. Second thing is that we know that over-the-counter dispensing of oral antibiotics has reduced tremendously. So we've seen a very significant drop over the past 10-15 years. And although obviously you can have occasionally one or two situations, but on the whole, OTC is not anywhere close to the worrying level that was in the past. So I mean, we have to be honest about this. I mean, most of the issues relate to prescribing. And in terms of prescribing, we have a number of situations, and maybe we can tackle this in a future session. We have a very high, at least compared to other European countries, a very high level of antibiotic use for conditions which are primarily viral in origin, flu, sore throat, etc. We also have a situation where antibiotics are regularly used to prevent bacterial infections, you know, this prophylactic ethos or concept which is not evidence-based. And for example, we know that you will need to treat more than 4,400 patients with sore throat in order to avoid one single lower respiratory tract infection. But the biggest concern, even when the treatment is indicated, is our levels or our choices of antibiotic. We tend to go for the very wide spectrum antibiotics. So our top 4 are penicillins with beta-lactamase inhibitors, second generation cephalosporins, the wide spectrum macrolides, and what we've said already, the quinolones, fluoroquinolones such as ciprofloxacin and levofloxacin. And the worry here is that these are the biggest drivers of resistance. So the wider the spectrum of antibiotic you use, the more you have the possibility of generating a resistant organism. And in this last slide, we can see that there are many studies showing that, for example, in this case, it is clarithromycin and azithromycin given to healthy volunteers, producing very high levels of resistance, which continue for months until they subside relatively close to where they were before.
Thank you, Profs, for your time. I trust, when addressing my audience here, I trust that this session has served to further your understanding of antibiotic use here in Malta and how to be stewards in the prescription of antibiotics. As rightly said, this session is part of an entire module on antibiotic use and infection control here in Malta, and I invite you to subscribe to our TheSynapse Facebook page and to follow us on this site. Thank you so much.